I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound.
So, in stent failures, stent thrombosis is one of the indications that should be seen by an IVUS if possible. So, the benefit would be that you can look at the stent issues if there is any stent issue which is responsible for stent thrombosis, or is it actually that there is no stent issue, then there must be either patient compliance issue or resistance to antiplatelets. In stent issues, you can look for under deployed stents, malopose stents, inflow, outflow issues, edge dissections, stent fractures, stent deformation. So, what do you see here? That's the stent, and that's the inner intimal layer. That's the intima, and that's plaque here, and then you've got media and then adventitia. So the stent should ideally be touching against the intimal layer. There should be no gap in between the stent and the intimal layer. So remember that this plaque here will never disappear. You can't make the plaque disappear, but you can push it back and the stent touches against the plaque inner wall. That's the intima. So because they are not touching against the wall, you can see that they are making rectangular and triangular appearances because there is no tissue touching them. There is a gap behind the stent strut. So this is a typical appearance for malapposition. Now, if you want to confirm it with chromaflow, you know that chromaflow is going to follow where the blood goes. So ideally, the blood should only be within the stent lumen, but here you can see the blood is tracking behind the stent struts. It's between the intimal layer and the stent. You can see chromaflow signals there. So this indicates that there is a gap between the stent and the intimal layer, and therefore this is again confirmation for malapposition. So this is an IVUS run again showing malapposition. So you can see here the stent struts. If the stent struts are in contact with intima, you cannot have this shadow going behind, and the struts will be very fine, and these shadows going behind will not be seen. So you can see again over here, looking at the same thing in a still image, you can see all of this shadow going behind. So this is malapposition of the stent. So malapposition is lack of contact of stent struts with the vessel wall. Technically, if you want to define it by measurements, then the axial distance of stent struts from the vessel wall should be more than 0.4 millimeter. This distance should be 0.4 millimeter, more than 0.4 millimeter, and in longitudinal length, this malapposition should continue for more than 1 millimeter. Then that's a significant malapposition. And remember, there is a difference between malapposition and under expansion. Under expansion we will discuss later. For malapposition, remember the stent struts are not touching the intimal wall. That is malapposition. So malapposition alone is not a definitive predictor of stent failure. Acute malapposition may resolve with time. OCT is definitely a better modality to detect malapposition. You can see how nicely you can see the stent struts here and then the intimal layer, and you can see that there is malapposition in this region. This is not a very, the resolution is not as accurate and nice with the IVUS as compared to the OCT for these intimal and stent structures for the luminal findings. So malapposition is a predictor of very late stent thrombosis but does not lead to acute stent thrombosis. And in the other problem with malapposition in cases like bifurcation PCI is that if the stent is malapposed, you have a tendency or a possibility of taking your wire. If you're rewiring it, there is a possibility that you go through the you go behind the stent struts and then enter into the stent rather than going from the middle, because you've got a space between the stent struts and the intimal layer. The other possibility can be tissue prolapse, which could be atherosclerotic, or in acute coronary syndrome it could be thrombotic material which hangs inside. Especially with cheese cutting effect, this material can come and hang inside the stent. It can be a predictor of early stent thrombosis and adverse short outcomes after PCI. And it's more harmful in the acute coronary syndrome cases as compared to non-ACS cases because these are usually atherothrombotic. They can even cause no reflows. So this is the case of a 55-year-old lady with unstable angina pectoris who refused CABG. So that's the LED disease you see over here. There isn't much of a foothold at the ostium. We thought there was disease going all the way into the left main stem, which has distal tapering. Then there is critical proximal disease, and the disease extends all the way up till this mid LED here. So looking at the size, if you want to judge the size, my personal opinion was that this is probably somewhere around 3.5 millimeter vessel, this LED, and probably 3.5 should be enough for it. So we did the IVUS, and that's in the middle you can see the IVUS run, but the ostial left main stem was 6 millimeter, shaft of the left main stem was 5 millimeter, LED ostium surprisingly was 4.5 millimeter. I was expecting it to be 3.5 or max 4. It came out to be 4.5. The proximal LED was 4 millimeter. LED mid MLA was 3.5 millimeter. These are the MLAs, the diameters. So based on this, we decided that that's the distal reference segment for us, 3.5 millimeter and a clean landing zone in the mid LED, which I just pointed out. So we'll start the stent from there. So the stent has to be a 3.5 millimeter stent. But since we plan to go into the left main stem, so one thing is for sure that I don't want to get into the ostium of the left main stem because the biggest size non-compliant balloon that I had on the shelf was a 5 millimeter balloon. So I could never oppose my stent in the ostium if I go to the ostium. So I'm going to avoid the left main stem ostium. LMS shaft is okay. So I will start my stent from the LMS shaft. It has to be so that I can make it a 5 millimeter. That I can achieve. And I need a 4.5 millimeter NC balloon for the LED. So I'll use two stents. 3.5 I will not be able to take it to 5 if I take it into the left main stem. So I'll use a smaller length 3.5 millimeter in the mid LED. Then I'll take a 4 millimeter stent for covering the proximal LED, the ostium, and coming into the mid shaft. And then I'll make it a 4.5 to 5 millimeter with non-compliant balloons. That was the plan. So this is a 3.5 by 18 stent which is being deployed distally. And then that's a 4 by 28 millimeter stent which is stopping before the ostium. It is staying in the shaft because I know that this is 5 millimeter diameter here. And then that is the final result. Looks good. So we used a 4 millimeter non-compliant balloon for the mid LED post dilatation, and then we used a 4.5 millimeter balloon in the ostium of the LED and in the left main stem at 16 atm pressures. So high pressure with 4.5 millimeter non-compliant balloon. That's the final result. So that looks like a perfect angiographic result. So we did an IVUS as well because this is left main stem, and that's the IVUS result. So you can see here that in the left main stem the stent is malapposed. I'll just come to that image there. You can see here. I'll show you this thing in still images now. So look at the distance between the stent and the intima. Look at that. And then look at these triangular and rectangular shadows that are going behind. Why? Because they are not touching the left main stem wall. So we already knew that the left main stem shaft was 5 millimeter in diameter, but we had used a 4.5 millimeter non-compliant balloon because of the ostial LED. And we thought that it might work for left main stem as well, but here you can clearly see that it's malapposed. So then we went in with a short 5 millimeter non-compliant balloon for the left main stem only, and we got a good result with that. And now you can see at the same point, that's the malapposed stent in the left main, and now this is a well-apposed stent here. So this is the final result then. This is a 48-year-old gentleman. He had primary PCI proximal to mid LAD in 2013 and a drug-eluting stent 3 by 28 millimeter was deployed. RC and circumflex were normal at that time, and this is that 2013 procedure. So this is not the recent procedure, this is 2013 procedure. So you can see here that's the LAD. Looks pretty good result. 3 millimeter stent. Looks nicely fitted in. But now in 2019, the patient came in with very late stent thrombosis, so 6 years after PCI. Thrombus aspiration was done, and then POBA with 3 millimeter non compliant balloon was done, followed by IVUS run. So that's the IVUS imaging. And so what you can actually see in the IVUS is, if you look carefully, when it goes into the proximal LAD segment, there you can see it's very undersized, it's malopposed. So what has happened here, we know it's a 3 millimeter stent, and when you look at the LAD in this region where it looks undersized and malopposed, it's 5 millimeter LAD there. At this point it's 5 millimeter LAD, 5.5 millimeter in fact. And when you look at the left main stem diameter, that is 4 millimeter. So this means that there was late positive remodeling which led to this very late malapposition and very late stent thrombosis. So if I show you the still images, that's very nice bifurcation you can see here, ostial LAD, and that is the circumflex. Just show you the bifurcation and the carina here. That's calcification with dropout shadow behind it. So that's the stent. This is a 3 millimeter stent. Here it is 2.8 millimeter opening, and then the vessel in this region is 5.4 millimeters. So it's grossly undersized for this, or you can say expansion is not bad because it's a 3 millimeter stent and you've got a 2.8 millimeter expansion with it. But gross malapposition, this is all very late malapposition leading to late stent, very late stent thrombosis. So now what's the concept of positive remodeling? We will discuss that later on. But if you look here, the left main stem is 4.3 millimeters. The mid LAD is 3.8 millimeters. But in between, the proximal LAD is 5.3 millimeters. Now left main stem is smaller, proximal LAD is bigger. So this is positive remodeling. You can see here that this is even bigger than the proximal segment. So this is called positive remodeling, and this we will discuss later on. So the next thing we did was that start moving forward. Sorry, just give me a second. Yeah, there. So the next thing we did, this is, we didn't want to stop our stent in the aneurysmal segment, so we decided to stent it from the ostium and overlapping it with existing stent, and we did that with a 4 millimeter stent and then post dilated it with a 4.5 or 5 millimeter balloon. You cannot touch your stent with the aneurysmal segment, but the concept is that the ectasia or the aneurysmal segment will collapse on the stent. So you don't try to touch it against the wall, because that way you will fracture your stent. You can't take it all the way to the 5.5 millimeters. So the 4 millimeter stent, we just went across the aneurysm. I'm sorry that I lost the final result clip for this, so I don't have the stenting image available. But we did it from the ostium, covering, going across the aneurysm or the ectasia. So in-stent restenosis is basically neointimal hyperplasia leading to ISR, and this appears more homogeneous and uniformly concentric, but could also be eccentric. So if you see, plaque is usually outside the stent, but if you see this kind of an appearance, which looks like there is some plaque inside the stent, but this one is going to be more homogeneous and uniformly distributed. So this inside the stent disease that you see is basically neointimal hyperplasia, and this is called ISR. And so this is homogeneous. and it's very wax-like slippery structure. So your balloon has a tendency to slip when you try to post-dilate this. So the ideal thing for this is cutting balloon. It will not slip and produce cuts in it. And then you need to look for mechanical reasons why the ISR took place at the first place. So you have to look at expansion, apposition, geographical miss, stent fractures, etc. So what's an underdeployed stent or under expansion? So under deployment or under expansion, you can see here that's the stent and that's media to media. So the stent is almost expanded to about 50% of media to media diameter. So this is under expansion or under deployment. And for good expansion, what's good expansion? So ideal is to get 80% of media to media expansion. If you go to 90%, that's excellent. But if you can get 80% of this media to media expansion, that's acceptable. But what's more important is that the final cross-sectional area of the stent should be more than 5 millimeters square for the non-left main stem, or more than 8 millimeters square for the left main stem lesions, or you compare it with the distal reference segment and it should be more than 90% of the distal reference segment. These are the criteria for a good expansion. So this is a comparison to show you that this is malapposition where the stent strut is not touching the intima. Look at this, this is malapposition. But look at this, this is not malapposition, this is under expansion. Look at the media to media size of the vessel and look at the size of the stent. This is under expansion or undersizing of the stent.
This is an example of a very calcific vessel where the stent implantation has taken place. And if you see the IVUS run, there's a lot of plaque modification that still needs to be done, and the stent is really not well expanded in that region. So if I show you the still images there, you can see the stent struts, and the stent diameter here is around 1.7 millimeter. This is not the MLA, this is the diameter that I'm showing, that it's a 1.7 millimeter opening of the stent. And if you look at the reference segment, there the EEL diameter is around 4.7 millimeter. So that's how big the vessel is, and this is how under expanded the stent is. This is all because the stent bed was not properly prepared.
What's a stent fracture? So the stent fracture can appear as missing stent struts, like you see here, there's a missing stent strut here, that could be fracture, or they can appear as stretched out stent struts, that's wires have unwound, and then there is also the gap between in between them has increased. Look at this gap that is increasing, look at this gap here, and look at the size of the stent strut, how stretched it is. So this is again a fractured stent, and remember that these stent fractures need to be restented.
This is a 52-year-old gentleman who had PCI to LED done 2 months ago, and now he presented with acute stent thrombosis, and this is the primary PCI going on. So you can see the occluded stent, thrombosed stent, and then it was pre-dilated with 2.5 and 3.25 millimeter non-compliant balloons. An IVUS run was then done to see the underlying mechanism for the stent thrombosis. That's the IVUS run. And what you actually see on this IVUS is that there are missing stent struts here. You can see here. So that's a fractured part of the stent, whether it was fractured initially and that led to stent thrombosis, or it is this 3.25 millimeter non-compliant balloon post-dilatation that led to the stent fracture. That's not for sure because we've done the IVUS only after doing the post-dilatation. But one thing we can see, despite of post-dilatation, there is malapposition as well. So a Zions Expedition 3.5 by 15 millimeter stent was deployed exactly at the site of the fracture. Now this is just a practice run to see how much we can identify now. So once the IVUS run completes, what we can see here is There is instant restenosis or new intimal hyperplasia that's visible inside the stent. In addition to that, there is malapposition here. The stent struts are not touching the intima. There is a gap in between. And then there is also under expansion uh, over here. So this is an undersized or underexpanded stent. Stent deformation can also take place. It can happen with by forcing the IVUS catheter into the stent, or it can happen with the use of a guide catheter when it goes in and hits the stent. So if the IVUS does not go through the stent, then don't force it. Just post-dilate the stent and then the IVUS can easily go through. Otherwise, the IVUS can actually deform the stent. Now, stent symmetry is desirable, but remember it's not always possible, especially in cases of heavy calcification. Forcing the IVUS or a balloon in under-deployed stent can deform the stent, and it may appear as a double layer of stents in that region. That is, the proximal stent edge gets folded towards the inside. Even the guide catheter induced deformation of stent, you can compare it with intussusception or invagination of the stent that appears as a double layer of stent struts in the area where the stent folded inwards, and that's what's seen here in this diagram. This is guide catheter induced intussusception. You can see the double layer of stents, with the red dots. We've tried to make things easier to understand. You can see that. So the stent, the initial part, the ostial part of the stent got folded inwards, both sides they've got folded inwards, and then remaining stent is fine. So you can see here the diagrammatic representation as well. So this is a 63-year-old female. Her lemur to LED is patent. There is an eccentric left mainstem lesion which is best seen in cranial view if you look at this one. And then there is a 60 to 70% ostial circumflex. So the decision was to stent from left mainstem across into the proximal circumflex. You can see here from here to here. So that was the plan. We directly stented with 4 into 28 millimeter Zions expedition. Ostial left main stent placement was done in iliocranial view. You can see that positioning very clearly, and we are covering the ostium. That's clear here. The post PCI result that you can see here. But it seems like in this view, if you see carefully, it seems like the stent has missed the ostium of the left main stem. But how is that possible? Because we just did the stent placement and the stent was clearly covering the ostium of the left mainstem. So to answer that, we did an IVUS. So IVUS, this is an IVUS from the circumflex post PCI showing areas of under expansion in circumflex and left mainstem. But what is interesting that there is also a double layer of stent in the left mainstem. This is invagination of the stent due to the catheter injury. There you can see that. This is the double layer of the stent which has invaginated inwards with the catheter injury. So we used another 4 by 12 millimeter stent in the ostium of the left mainstem, overlapping with the previously deployed stent, and then post-dilated with the 4.5 into 18 millimeter non-compliant balloon. And then ostial flaring was done with the same 4.5 by 18 millimeter non-compliant balloon. This is the final IVUS run showing a posed and expanded stent with ostial left mainstem coverage. And this is the final result. This is a case where I performed Q-lot stenting, and after port you can see looks like a perfect angiographic result, but I wanted to be sure, so I've done an IVUS run, and the IVUS run was very interesting. So if you look at the IVUS run carefully, what do we see? I'll show you in the still images, but it's important to see the run again, so I will let it play. So what you see here is that in the initial part of the stent, the struts are actually collapsed proximally. You can see here they are towards one side
Here you can see again they are towards one side, all cramped up, and there is no stent coverage on the other side of this artery. So why and what happened? So basically what happened was that the wire position was lost. After performing the Culotte stenting, the wire position was lost, and we wanted to do another pot, but the wire entered the stent from behind the initial few stent struts, and then it entered into the stent lumen. And somehow I did not realize that the wire had gone behind the stent struts, and surprisingly the balloon also went in very smoothly, and it was a new balloon which we were using for the pot, and it did not give any resistance. Otherwise, a lesson to remember is that whenever you are recrossing a stent, there is a possibility of your wire going behind the stent struts initially, but the slightest of resistance that you get with the balloon, you should be very careful and you should recheck your wire. In any case, in this case, I've gone in with the balloon and inflated the balloon so that initial part of the stent struts collapsed, and that is what you see here on one side of the stent struts, and the remaining half of the stent is perfectly fine. There's no problem with that. The culotte angulation and all did not get disturbed, but the initial part of the stent is deformed now. It is collapsed. So we had no choice but to go ahead with a new 4mm stent that was placed overlapping the collapsed stent part with a good final result. And what the IVUS shows is a nice bifurcation forming figure of 8 appearance and well opposed stent. You can see the figure of 8 appearance here. That's a figure of 8 appearance. So LAD and diagonal. So this is a 50-year-old gentleman who had angioplasty done to the right coronary artery with a 3 by 38mm drug-eluting stent about 6 years ago, and now he presented with very late stent thrombosis, and this is now primary PCI of the right coronary artery. So it was pre-dilated with 3mm balloon, and TIMI-3 flow was established. IVUS was done to identify the reason for stent failure, and you can see that the IVUS shows area of malapposition and under expansion with mild ISR and some thrombus. Stent was 3mm in diameter, whereas the RC at some points was 4.5 to 5mm vessel. Now these are still images to show the disease. So that's the plaque, eccentric plaque here in the distal RCA. There is some thrombus there, and then this is instant restenosis. This is the stent diameter, which is 2.8mm, and then this dimension is the media to media, that's the vessel size. This is 4.8mm, so it's a 2.8mm stent in 4.8mm vessel. That's almost 50% of the vessel size. So this is under expansion. There is area of malapposition here. Stent is not touching the intima. Another area of malapposition here, and then chromoflow was done to confirm the area of malapposition, and we know that the chromoflow color follows where the blood goes, and you can clearly see that there is this collection of the color here between the stent struts and the intimal layer. So this is a clear area of malapposition, which you can see here as well. So dilated the stent with 4mm non-compliant balloon at 16 atm pressure, and then repeat IVUS was done, which showed persistent area of malapposition and few segments which had now a fractured stent. So basically there were missing stent struts in this. So now you've got a stent fracture to deal with. There you can see these are the missing stent struts. So here in the still image you can clearly see stent struts are missing here, stent struts are missing in this region. So this is stent fracture. You can see the stents here, and then some strut here, some strut here. This is all missing segments of stent. So this is a fractured stent. So another 4 by 48mm drug-eluting stent was deployed within the original stent, covering the proximal and distal heavy plaque burdens. You can clearly see here 2 layers of stents where the overlap segment is. So this needs post dilatation. So it was post-dilated with 4.5 millimeter non-compliant balloon. So under normal circumstances, looking at the angiogram, probably we may not have used a 4.5 millimeter balloon. But now having done IVUS, we were confident that it needed a 4.5 millimeter NC. And now you can see how well opposed and fully expanded the stent is with a cross-sectional area of 13.2 millimeter square. We optimize stent expansion based on the lumen area and not on plaque burden. Plaque will always be seen behind the struts, it cannot be made to disappear. Your stent struts can not be seen touching the adventitia unless you have stented a normal artery. So we are only expanding the lumen area. What you need is that the stent should be fully opposed, that is touching intima at all areas and well expanded according to the calculated area as per the distal reference segment or 80% of media to media. Don't worry about the plaque that is seen behind the stent. In the right sided figure, you can see a stent deployment in the calcific artery. There's calcium here, there's dropout shadow here. The stent is not very circular. So in this case, you may not be able to achieve a complete circular stent shape here because of this calcium. But then if the cross-sectional area is acceptable, then you can accept this result. Now this is a 57-year-old lady who presented with effort angina CCS3. You can see the mid-RCA lesions. If you look at the size of the right coronary artery, I think it looks like a 2.75 or a 3 millimeter artery at the max. So after pre-dilatation with 2 by 20 millimeter balloon, this is the result. So then two stents, as I said, to us this looks like a 275 and 3 millimeter vessel. So a 2.75 33 stent distally and proximally overlapping stent 3 by 28 millimeter till the ostium. They were deployed. The stent was post-dilated with a 3 by 20 millimeter NC balloon and ostial flaring was also done. At this point, this was my interventional fellows doing it, and this point they involved me because they saw some haziness in the ostium of the right coronary stent after the post-dilatation. So I decided to put in an IVUS catheter, and this is the IVUS run. So if you see the cross-sectional area, what you would notice is that in the initial part of the stent, as the IVUS catheter enters, it is outside the stent. The IVUS catheter was clearly outside the stent, and you can see that clearly on the longitudinal run also. If you see the longitudinal run, with the stent you would always see stent struts on this side and this side, this side and this side. Instead, you can see complete stent over here, whereas the IVUS catheter is running here. And then in the later part, the stent becomes okay. But how come this stent is outside the IVUS? So the only explanation is that's only possible if the wire had gone behind the stent. So at this point in time, I asked my colleagues, did you have to rewire? And they told me that yes, after deployment of the stent and before doing the NC balloon, they lost the wire. Everything fell out. They rewired the stent and then they did NC balloon, a new 3 by 20 millimeter balloon. So that's what happened. The stent initially entered behind one or two stent struts. It was probably not well opposed, so the wire went behind, and then it entered the central lumen of the stent. So their dilatation of the balloon actually collapsed the initial part of the stent. So having seen that, now I tried to rewire through the collapsed lumen. I tried multiple times. It never works. I could never figure out where the true lumen was, and then I decided that this is not a very positive activity. I'm going to take the whole day standing here and not succeed. So then I went on to put in another stent to fix the collapse issue. So this is a 4 by 12 millimeter drug-eluting stent deployed at the ostium through the strut. And then I did the ostial flaring. And this is the IVUS after that. So you can see over here, that's the collapsed part of the initial stent, which is now behind the new stent. You can see it here. This was the initial picture. And now it is like this. And this is how this stent, collapsed stent looks. Cannot be collapsed any further because this is right at the ostium. You can see that ostium wall on one side and that's the aorta on the other side. So we have got good osteal coverage, but we cannot collapse this any further. So this patient also needs long-term dual antiplatelet therapy. But if you notice another thing, this is the final result, that we initially started off by using 2.75 and 3 millimeter stent because that is what our angiographic appearance was about the size, impression was about the size of the vessel. But now, having done IVUS, I have used 4 millimeter MC balloon and 4 millimeter stent because on IVUS this vessel was much larger. 85-year-old gentleman who had PCI to mid LED with a drug-eluting stent about 3 years ago presented now with unstable angina. So he had this critical osteal LED, and when we did an IVUS, the osteal LED was 4.5 millimeters in diameter and the left main stem was 5 millimeters in diameter. We decided to do PCI of the left main stem to LED. So pre-dilated with 3 millimeter balloon, 4 by 28 Promus Premier stent was deployed from proximal LMS to mid LED. Post-dilated with 4.5 by 8 millimeter non-compliant balloon at the LED ostium and 5 by 8 millimeter in the left main stem. Now there was a lot of difficulty in bringing the 5 millimeter balloon back into the catheter. Probably the balloon was not deflating sufficiently or whatever, but there was a lot of push and pull and the guide catheter was coming in. The balloon just would not come back. Finally, we succeeded in removing the balloon, and after the balloon removal, this is the image that we got. So if you look carefully, there's something over here which if I give you a magnified view there, now you'll be able to see it better. Look at this. There's a part of the stent that is hanging in the aorta now. It's outside the left main ostium, it's outside the guide catheter tip, and it is hanging here. There's a metallic structure hanging in the aorta. So I think what happened is that the stent got fractured and deformed because of the guide catheter and balloon interaction that was taking place, pushing and pulling. So the stent is damaged now and it's hanging outside. We did an IVUS run to see how it looked. So this is a complete IVUS run, shows that the mid LED, proximal LED stent is well deployed, it is fully opposed, but as you come towards the ostium of the left main, as you come into the left main stem, you see that the stent is fractured here. I will show you the still images to see the fractured part, and then as you move further backwards towards the ostium, you see that the stent is collapsed and it is collapsed completely to one side, and now the IVUS seems to be outside the stent. The stent is here. You can see the whole stent collapsed and it is outside the left main, the IVUS. And if I show you the still images here, this is the fractured stent. You can see stent struts on one side, there's stent strut here, all stent struts here are missing. Again, stent struts missing on all sides. And the other thing you notice is IVUS catheter is sitting outside the stent. The stent is collapsed here. That's the stent lumen. The whole stent is collapsed here. Again, you can see here the whole stent is collapsed here. Here you can see there is the left main stem wall on three sides. On one side it is aorta. So this is hanging outside now. So the first thing we did, we dilated the stent part in the left main again with 3 millimeter and then 4.5 millimeter balloon to make space for a new stent. Brought in a 4 by 32 onyx covering the left main stem ostium this time, and post dilated with a 5 millimeter non-compliant balloon and also did ostial flaring, and this is the final result. So result is good. And if I show you the dry cine, you can see that behind the ostial part of the left main there is a collapsed stent part visible here, and on this image you can see here outside the stent, there you can see this part which is hanging outside, this small part here. And this is the final IVUS run. You can see the fully expanded stent, but the collapsed segment of the previous stent seen in the aorta here. And if I show you this over here, so this is the still image now with the LMS wall on one side, and on three sides there is aorta. So this is true ostial coverage of the left main stem, and then you can see the collapsed part of the stent there, that's double stent. So this is now outside the ostial stent hanging in the aorta.
So patient is on dual antiplatelet therapy lifelong.